Your hand up. I don't get this much insurance people as we have employers. Okay. So my name's Dan Malin. It's a pleasure to be here today. And what I'm going to try to do is give you a little perspective on what's going on in the healthcare industry, and then talk to you a little bit about what's driving our costs. And obviously, we all know what the Affordable Care Act. Our system is broken. Would everybody agree to that? Okay. The question is, just how broken is it? So one of the things I'm going to warn you about is I am going to depress you. All right, you're not going to like me when I get done because I have a lot of things to talk about that are very depressing, but I also have a lot of things to talk about that are very positive. And I thank Mike for having me here. Mike's really one of our good brokers, and he knows what we do really well. So what I'm here to do today is talk to you about a concept called level-funded health plans for small groups. And essentially what this is a process whereby you as a small employer can start to control and manage better the cost of health care and health insurance for your employees. And you're going to see why when I get into this in a little bit. I'm going to give you some illustrations. So why are we talking about level funding for small employers now? And what's the primary purpose? What are the benefits? And then how many of you, if I say self-funding, go, wait a minute, I don't want to be there. Self-funding means what? Self-funding means I'm writing checks out of my own pocket. Well, I can do that up to a point, but I can't really be self-funded because I don't know what the liabilities are. This is level-funded health plans, so I'm going to explain to you the difference and how that works. And then I'm going to share with you some very, very cutting-edge new ideas, what we're going to call direct primary care wrap programs, and I'll just kind of leave it right there for the moment and talk to you about some next steps. So one of the things I want to talk about is the small group market. What is the small group market in the United States? Well, these are the states we do business in. And if you look at the state of Texas, there's 156,000 firms that employ between 5 and 99. They employ 2.6 million people. So the reality here is we've got a marketplace. And what's interesting is if you look down the total, there's about 17 million people in that space in the United States today. Now, that 17 million people is spending over $100 billion a year for health care. 100 billion with a B. We are spending 18 cents of every dollar in the United States today for medical services. We have the best medical technology in the world. We also have the most expensive medical technology in the world, and it's getting more expensive every day. How many have noticed lately that hospitals are building? Why do you suppose they're building? Where do you see most of the construction? It's all around hospitals, right? Well, the reason is because they think all of us baby boomers are going to die. My daughter looked at me one day and said, "Dad, it's going to cost you $1 million to die." Who's paying for that? Okay? But that's a reality. But we have an aging population, right? That's one of the issues that we're going to talk about in a minute. So, why level funding now? This is a really simple illustration to show you what's going on with medical rates, and I'm going to show you why. But in 2014, if you were an employer and your employee-only rate was $325, the dark line kind of shows you the trend, which is running around 12%. But when the Affordable Care Act came along, either now or in the very near future, you're going to see that rate go from $325 to $500 for a variety of reasons, all predicated on what the Affordable Care Act did, which is basically added some provisions to health insurance, like unlimited lifetime maximums. They created a guaranteed issue. People can come to the plan when they're sick and get guaranteed issue. So the things that they did that actually escalated this. How many are aware that the Aetna insurance company just decided to withdraw from a bunch of exchanges? All right? Why did they do that? Because they can't make any money. What do you mean they can't make any money? I will explain to you why, and you'll see this. But the whole idea here is that we're looking at costs that were $325 in 2014. By the time we get to 2019, are going to be close to $700. Okay? That's where healthcare costs and healthcare insurance is going. Question is, what are you going to do about it? Well, the level-funded health plans for small employers are going to become one of the options. These are some of the things that happened in the Affordable Care Act. We had community rating. They added that to the provision of health care. Pre-existing conditions are now included. We have a guaranteed issue contract. They expanded benefits. One of the things the Affordable Care Act did is it added, on a fully insured contract, pediatric dental and vision are now a fact. You have to include that. So guess what? There's a cost associated with that. And they also changed the age slope rating from a 5 to 1 to a 3 to 1. Now, everybody's looking at me going, what the heck is he talking about? Let me explain it this way. Prior to the Affordable Care Act, we were dealing with a 5 to 1 age slope, which means the 20-year-old, you had $600, 20-year-old was paying $100, and the 60-year-old was paying $500. What they did with the 3 to 1 age slope, now the 20-year-old's paying $150, and the 60-year-old's paying $450. So the poor 20-year-old just got a 50% increase in his cost, right? Why do you think so many young people are not buying health insurance these days? Because they got a 50% increase in their rate, okay? They said, wait a minute, we're not here to, and the Affordable Care Act has had a real struggle getting young people to enroll. Older sick people buy it all the time. They're very, very excited to have it. But the younger people who they wanted to attract basically went away. Well, we in the marketplace understand if you raise the price on something that people don't need, they're less likely to buy it. Hello? It just doesn't make any sense. Do not let a politician run your business. So, let's look at the annual cost of health care. This is a Milliman study that recently came out. In 2001, the annual cost for a U.S. family was $8,414, and the RX cost was $1,100. The RX was 9% of the total. And the employers were paying 61%. That was 2001. Now, fast forward to 2015. That cost is now almost $26,000 a year. If you project this out to 2020, projected family cost for health care $32,000 a year. How many families out there only make $32,000?
What consists of a family in this study?
What's that?
What consists of a family?
A family is a unit of 4 people.
Okay, thanks.
Okay? It's a unit the average household in the United States has about 2.7 people in it. Okay? But this is a Milliman study talking about the family, a typical family of 4. So here's another way to look at this, and this is a Kaiser study. This is individual looking at group health plans, or individual health plans and a family plan. So in 1999, an individual plan cost $2,196. That's about $185 a month. If you had an insurance company that would take all your medical risks today for $185 a month, you'd write a check and dance all the way to the bank. Okay? The point is, you don't look at self-funding when it's $185 a month. 2013, that same policy now costs you $5,800. And if you project an 11% increase without the Affordable Care Act, that policy in 2020 now costs you $9,900, almost 10 grand. If you throw all the provisions of the Affordable Care Act, you're over $1,000 a month for an individual health plan. Heaven forbid you should be a family, because the family cost now is at $33,000. We have just seen in the last 3 weeks, we had two proposals we worked on, one in Ohio, one in Missouri, where the family rate on the renewals from Blue Cross and Blue Shield was north of $32,000 a year. We've already seen it. It's not like it's not out there. In Texas, you haven't seen any of that yet, but we've seen it in other states already. So this kind of gives you an idea. Health insurance or health care inflation is running 11%. The trend of increasing cost of health care right now is running between 10 and 11% per year. Okay? You add on top of that the fact that your group is getting a year older every year, which means you're going to get a demographic trend increase as well, which is worth at least, the younger the group, it will be at 1%, but if you have a group that's over 40 years of age average, the demographic trend adjustment is 2%. And if you get closer to 50, it's now 2.5%. The older you get, the more likely there is to have health conditions. And so trend adjustments for groups with an average age of 50 or more could be run as high as 13 or 14%. So here's the estimated group premium. In Texas in 2016, that 5 to 99 group is going to spend $15.2 billion. By the year 2020, that cost is going to go up $7 billion. That's how much more money they're going to spend by 2020. Now, if you're an insurance agent in here and you're making a commission, this is not a bad deal. Now, what is driving all of this? Well, there are people out there that go, well, it's the lawyer's fault, or it's the hospital's fault, or it's whatever. There's 11 different things that are, and I have an entire PowerPoint presentation just on this. So all I'm doing here is giving you a snapshot of some issues. These are the things that are driving the healthcare costs today. First thing is business practices. Marginal business practices of the government. Does the government have marginal business practices? Hello, okay. And also the insurance companies. Insurance companies are notoriously inefficient, okay. Providers, medical vendors, suppliers. How many, when I say mercenary pricing, know what I'm talking about? People take advantage of sick people, all right? There's a lot of mercenary pricing, especially in the drug companies. Transparency. How many of you know what it costs you to go to the doctor?
Right.
Nobody knows. It's a big mystery. Okay, litigation. How many know that there's an awful lot of defensive medicine that's being practiced? There's many, many, many tests that they run on you because the risk manager at the hospital says find out what's wrong with it and make sure you don't miss it. So there's a lot of medicine that's being practiced that's defensive medicine. Wellness, we've got unhealthy lifestyles. The media's not helping this. The media's promoting an entitlement mentality. Let me ask you a question. Is health insurance a right or a privilege? It's a privilege, okay? Everybody in this room knows it's a privilege, but there's an entire population that think it's a right. There's an entire population, and the difference is not what it is, it's who pays for it. If it's a privilege, we pay for it. If it's a right, we pay for it, but we pay for it collectively, right? Consumer education. We need more informed medical consumers. That's part of why I'm here today, is to give you some education about the bigger picture here. For two reasons. Number one, if you're a broker or an agent, you need to know the big story, and if you're an employer, you got to get your arms and your head around this issue, because it's not going away anytime soon. Technology. We had an interesting conversation. We had this conversation a bit ago. The technology question. The state-of-the-art medical technology prolongs life. We got people that normally 7 to 10 years ago would have died, okay? And we spent tens of millions of dollars keeping people alive that historically have not been alive. Now, this is a really dramatic moral issue, but in a minute I'm going to show you a chart that's going to explain why this is such a big problem. And I don't have a good answer for it, but it is part of the problem. And when you start unpacking what the issues are, you can't avoid, because this piece right here is incredibly important. We have the best medical technology in the world. How many of you had a knee replacement or a hip replacement? Okay, my sister-in-law's had 2 hips replaced. 20 years ago, that never happened. Okay, those hip replacements are $150,000 per. All right. The point is that somebody got paid to do hip replacement, right? So we've technology, aging population. We talked about that already. I'm one of those. Government. The government has put cost of compliance. One of the big issues as a broker is that you now not only are an agent, you got to help your employer through the whole compliance issue. That's why guys like Mike become so valuable, okay? But the cost of compliance, the ACA, electronic health records, and additional taxes. And then obviously we have politics. So how many of you have a political crystal ball they want to look into today and tell us what's going to happen? Okay? And we could have a nice conversation about that, none of which would be relevant because none of us know. But the reality is, and I did a presentation in Houston, the Houston Association of Health Underwriters on Wednesday, and I said, guys, change is about change, and it's going to continue to change. Only things we don't know what it's going to look like. We have no idea. So the volatility is still very uncertain. But the last thing here is catastrophic claims. I'm going to spend a minute talking about catastrophic claims because this is the real key. Between 2004 and 2011, the average increase of claims in excess of $2 million was 70% a year. We have claims right now that are running 5, 6, 7, 8, 9, 10, 11, 12 million dollars for one individual because they can sustain their life. And the hospitals and the major medical facilities love these cases because they can continue to charge, even after network discounts. So the city of Fort Worth, Texas, last year, 2015, they have 1,600 employees. They have 2 claims in excess of $5.5 million. So the $11.5 million worth of claims with 2 people. And since they're self-funded, all of those dollars come out of the budget of the city of Fort Worth. Was that sustainable? No. We got rid of the unlimited lifetime maximums, so the hospitals and doctors basically are looking at these cases as a gravy train. Now, that's a really arcane way of looking at it, but at the end of the day, you kind of see where this trend is going. And what's happened is that because they've taken off the unlimited lifetime maximums, the stop-loss carriers and the people who are taking risks, we just talked about this with my friend here from Aflac, you know, that's why Aetna is departing the Affordable Care Act and the exchanges, because these catastrophic claims is what's showing up in the exchanges. People who come to the exchange have health issues and they come for a reason because they're a hemophiliac. A hemophiliac's $1 million a year if they go to the hospital, because they're going to continue giving transfusions. So let's change this a little bit. What is self-funding? Why are we talking about self-funding in this context? So what is self-funding? First of all, it fully insured, the risk bearer is the insurance company. You're going to write a check to the insurance company, they're going to take your risk, and you're going to be done. All risk transfers. When you go to a self-funded or a level-funded plan, your employer is now the risk bearer. Okay? You are now the carrier. And your claims are going to be paid from your claims fund, which we're going to explain in a minute. The employer hires and assigns a claims administrator, which would be Allied, and then you purchase what's called a stop-loss policy, which is taking care of the catastrophic risk, because obviously, as a small employer, you cannot afford a $10 million claim. So you're going to buy insurance, but you're going to buy catastrophic insurance, not primary insurance. So what happens is the specific stop-loss, and we'll show you an illustration, and I think there's one in your packet that'll explain this on one piece of paper, but one individual's claim your loss fund. So if you put $50,000 in your loss fund, you're limited to, let's say, $10,000 any one claim, and then a maximum on the aggregate of $50,000. I have an illustration that will explain it a little better here. So now let's talk about the difference between self-funding and level funding. In the self-funded world, basically your claims liability is variable and unknown and based entirely on claims costs. So if you go, for example, the city of Fort Worth's got 1,600 employees, and the city manager basically said, health insurance is the only thing we buy that we don't know what the cost is until very much later after our budget year. So we can't budget for it. We don't know what it's going to be because it's all driven by claims. Well, you as a small employer can't play that game. Okay? So we've created what's called a level funded plan, where the ultimate costs are capped and limited to a specific dollar amount. And typically the level funded plans are limited to 12 equal monthly installments. And as far as Allied is concerned, we'll do those plans down to 2 lives. And I'll explain why here in a minute. So, why are we level funding? Well, long term, it's the most cost-effective way to finance a group health plan. You basically get rid of the insurance company profits, you eliminate some of the premium taxes, you can eliminate some of the benefit mandates that are required, so you can take that pediatric dental and vision out, you don't have to pay for it. This is an ERISA plan. It falls under a federal guideline called, how many familiar with ERISA? You know what ERISA? Employer Risk and Security Act, 1974. It also allows the employer to take control of the benefit plan, but the 2 most important things are, number 1, money not spent on the claims belongs to the employer, not the insurance company. 50% of the employers that are on our plans get a check back at the end of the year. How many of you have gotten a check back from an insurance company lately? Nobody, right? So we actually give that back. So, and the other thing we can do, because it's an ERISA plan, we can discriminate in the rates that we charge to you versus the next employer. So if you have an employee, or if your employee group is fundamentally healthier than the community at large, you're going to get a better rate from us. If you have somebody that's got a serious medical condition, we're probably going to decline the risk. So there's a qualification process you have to go through. But at the end of the day, if you can qualify for our product and our program through underwriting, you're going to save money on the front end and potentially on the back end. So what is it? This is called Funding Advantage. It's the alternative funded small group or level funded small group health plan. We call it self-funding on training wheels. 2 or more lives. It's simplified. One of the challenges you have, and part of the reason Mike is valuable in this process, is many agents who have dealt with traditional self-funding over the years see this and don't understand it. That it's a disconnect for a lot of agents because they've been drilled in their head, self-funding is a bad thing. Self-funding is not a bad thing, you just have to understand it. Okay? Everything's pre-packaged, the plan docs and specific and aggregate stop loss, and we create the rate, all that's included. Level funded plan, I don't have time to get into it today, but those of you that understand self-funding understand what terminal liability is. In traditional self-funding, if you decided to stop, you got to continue writing checks to pay claims until all the claims are done. In our plan, all that's included. You basically make 12 equal monthly installments and you're done. The terminal liability is built in. Okay? And also it's medically underwritten, which means you have to qualify. Your price and your price and your price and your price could be totally different even though you all have 10 employees, all based on your health. So the rates are totally different. class, and it's medically underwritten. And there's an accommodations provision which basically, if you run out of money in your claims fund before the end of the year, the carrier advances that a loan to the employer at no cost to the employer. But the employer still has to make their subsequent. If you don't make all 12 monthly installments, you're in big trouble as an employer. So, I believe that this chart is in here. Let me make sure. I should have checked this before. Yes, it is. So, I would encourage you not to look at it yet, but when you take it home, it's right here. It's in your packet. So, what we have here is, this is on one piece of paper, and I think I'm one of those guys that if I'm going to explain to an employer, I like to sit down with you across the table and have one piece of paper we can look at so we can explain it. Mr. Employer, in this case, is spending $122,000 a year, which is approximately $10,000 a month. All right? Instead of writing the check to the insurance company and them just putting it in a bucket you'll never see, we put the dollars go into three buckets. The first bucket is the claims fund, and in this case, it's $53,681. That represents the green box right here. Then we have the stop loss insurance, which we're paying $46,868 for. That's the real insurance. That's where the carrier is actually taking your catastrophic risk. Okay? And then we had administration and sales fees. That's the fees that come to us for paying your claims, and it's the agent's commission. So it's $22,000. So what happens here is this particular illustration, we've got what we call a $10,000 specific stop loss, which means every claim that occurs, the employer's loss fund, which they're paying into every month, is going to respond up to $10,000. Beyond $10,000, then the carrier is going to pick that up. So we have a $25,000 claim here, the first vertical bar. $10,000 of it comes from the employer, the rest of it comes from the carrier. We move over to the next one, we have a $4,000 claim and an $8,000 claim. Those two claims are paid 100% by the loss fund. Everybody follow me so far? Everything's making sense. So the next one's a $45,000 hernia. We got $10,000. Again, that's all the employer's obligated for, but the carrier picked up $35,000. So we had a series of claims here, 1, 2, 3, 4, 5, and down here is a whole series of other ones that was total up to $4,000. But at the end of that period of time, for 1 year, we spent $43,000. How much was in the loss fund to start with? How much did they put in? They put in 53. So how much was left over? It's $10,681. Guess what? We gave them a check back for $10,681. Would that be a good day? Most small employers, 3 out of 5 years, will get a check back. Okay? Now you got to qualify. Now what would happen? Let's talk about this for what's the worst thing that can happen here? Worst thing for the employer. You're going to spend $122,000 and you had some additional claims and you spent that $10,681 and the aggregate stop loss over here at the end actually had to pay a claim. Your cost didn't change. It's still $122,000. So the exposure is picked up both on a specific and aggregate basis by the stop loss carrier. Okay? A lot of agents that have been doing self-funded in a traditional methodology, not our methodology, look at this and it just blows their mind. They're not ready to explain it. They try to make it more complicated than it is. They ask a lot of questions. Well, how can you do that? Well, we have an actuarial model that works quite well. I would encourage you to take this with you, take it home and study it. Pick up the phone and call Mike, ask. If you can't figure it out, ask Mike to explain it to you. Can you explain it to him? Okay, so here's the worst case scenario. And what happened is we spent all the money plus the carrier, okay, they actually had to spend an additional $12,819 that was paid by the aggregate stop. In this instance, the employer got no money back. Now the question is renewal. What happened to renewal on this deal? Well, interesting you should ask. You didn't ask, but I asked for you. Okay? So what we have here is this big claim right in the middle was a hernia. It's a one-time deal. We don't care about that because it's over and done and said and not a problem. So it's not reflected in the renewal. However, this little guy down here that never hit the spec down here, it's a $5,000 claim. That's the beginning of a colon cancer. So as we get to the renewal, that's going to be reflected in your renewal rate. Now, having said that, right now, Allied's renewing 83% of their business. And what's interesting is we offer a renewal to every single client. Now, if you really have a lot of bad medical conditions, you're going to get what we finally call a go-away rate. Okay? You may get a 90% increase, at which point you're going to go back to the fully insured market until that problem goes away. However, what's interesting is we get some 40 to 50% renewals that don't go away. because comparable to the fully insured rate, it's still a better deal than what they have. So just because you get a big rate increase doesn't necessarily mean you're not going to stay with us. And we keep a lot of our business. Let's talk a little bit about what the plan does. That accommodation, when the claims exceed money in the claim fund, the insurer loans the employer the money. So that first claim that you saw there on the left-hand side, the $25,000 claim, let's assume that that happened in the first month and the employer had only contributed $5,000 to the claim fund. So he's short $5,000. Well, the carrier will put the money in that claim fund until he catches up the next month and the following month and the following month. As long as he makes his 12 equal monthly installments, he's fine. The other thing is detailed reporting. How many of you as small employers have actually seen detailed claims information on the claims that are occurring in your group? Zero. You don't see it. We're going to show it to you every month. We're going to show you the balance in the claim fund, and I'll show you that in a minute. It's a 12/21 contract, which means you're going to pay premiums in for 12 months. We're going to pay out the rest of the claims over the next 9 months, and then we're going to cut it off at the end of 9 months. In the 11th month, if there's money left over, you will get a check. So it takes 11 months to actually physically get the check, but it takes 9 months for the claims to run out. So claims incurred during the plan year payable for 9 months. The end of 9 months run out, all remaining claims belong to the employer. So this is an example of the claim balance, a report that comes out. And by the way, this would be available on our website for you as an employer. Okay, so here you see the contribution to the claim fund. They have put $55,608 in their claim fund, and to date we've paid out $36,000. So as of the end of that month, there's $19,000 left in the claim fund. So you get to watch exactly how much money is left in your claim fund all the way through 21 months. It's not a mystery. You basically can figure it out. It's your money. We have a fiduciary obligation to show you the balance in your claim fund every month. That's part of our role as the third-party administrator. We've got these are some of the red list, which are the underwriting. You know, if you have one of these medical issues in your group, then you're probably not a candidate for Levelfunding. The other thing is how do I get involved? Well, the first thing you do is you call Mike, but this is what Mike's going to ask you for, and we're going to go through accurately completed enrollment forms, which basically is a medical application. So how do we do this? Well, you're all my group. So what you're all going to do is you're going to complete a medical enrollment form. It's excuse me, it's 2 pages. First page is demographic information. Second page is a medical questionnaire. That medical questionnaire is going to come in, and we are going to calculate each one of your medical consumptions for the next 12 months. We're going to look at 3 things. We're going to look at office visits, we're going to look at RX consumption, and we're going to look at the chronic and critical illnesses in the group. And we're going to assign a value to that based on what we know to be costs for those things for the next 12 months. We add all that together for the group. That's the basis of the rate. So medical conditions are all over the board. It's either paper or online enrollment. The employer has to complete an application. If there's people that are waiving, we need that. We did current wage and tax. There's an account transmittal form. We want to see the current renewal rates or renewal rates. We want to see what you're currently paying, not so we can shadow price, but because our time and Mike's time and your time is extremely valuable. If the Blue Cross people have offered you a $430 rate and we've given you an initial quote at $410, we're probably going to say you're not a fit right now. Let's see what happens. But if your renewal rate at Blue Cross is $565 and we start out with our base rate at $320, we now have room for underwriting. So there may be a reason to look at it, maybe not, but we want to see the current, and we want the proposal that Mike will have given you to showing the benefits, because we have our benefit plan design. We literally do 4,000 different plan designs. So we customize our plan designs to fit the medical conditions inside the group as they stand on the day we underwrite it. So one of our prevailing cultures here is underwriting trumps sales. If Mike brings us a case and he says, Dan, I can't sell that price, we're going to say, thanks, next. We only want our cases at our price. Now, we will negotiate based on coverage and based on benefit design, but we will not alter the price because we're trying to come up with an actuarially sound number across the entire pool of business that keeps us in business. If we don't stay in business, so it says, since our core product offering is small group level funded plans, Our ability to continue to offer those products over the long term is driven by underwriting profitability, the overall pool of business. Why is Aetna getting out of the exchanges?
Not making any money.
They can't make any money. And why can't they make any money? Because they can't underwrite. They're not allowed to underwrite under ACA. If they could underwrite, they could come up with a rate that allowed them to stay in the pool. Well, if we're going to stay alive in this world, and at the fundamental issue here is this reality, even though they're the ACA and they're an exchange, they're an insurance company. They've got to make money or they're going to go out of business. How many of you would be in business if you didn't make any money? Okay? Insurance companies know their business very well, and they know there's an actuarial reality to everything that happens. Now, there's a debate. You can debate all along what their costs and their overhead and expenses, et cetera, but at the end of the day, 85 cents of every dollar paid to an insurance company gets paid out in claims. So whatever their costs are, plus or minus a couple of points, is not really relevant. Okay? What's relevant is what's the cost of the claims. So our underwriting profitability of our pool of business basically keeps us in business. So we follow a very disciplined approach to underwriting every risk, both in new business and renewal. Good risks get favorable rates and poor risks are declined. Best rates have an opportunity to participate in the underwriting profits on their account. So if you're a good risk, even if we charge you too much and you don't have any claims, guess what? We're giving you money back. Would that be a good day? I'm going to tell you what, my agents get so excited about returning checks. Oh my goodness. It is great days when they get to do that. And it happens quite often. So, go forward here. Here's an example of an underwriting load report. And I'm going to go through this because I think this is insightful for you guys. So we have husband and wife. Spouse has taken some anxiety medicines and she's got some issues going on. So she's got office visits. She's going to do 3 of them at $450 each, and then she's taken $1,421 worth of meds. She has no major medical exposure, but he's a mess. Okay, he's a diabetic. He's taking injections. He's doing some anxiety disorder medicine. So, and he's taken about $4,800, $4,900 worth of drugs, right? So if you looked up here, this particular couple is consuming $14,429 worth of medical services that would be paid for by the plan. This calculation is done on every belly button in the group. That's the basis of the rate. Interesting process, right? Wow, this guy's crazy. So, once we've gone through that process, we're going to give you a firm rate, okay? And you can manage the rate by changing plan designs. There's lots of different ways, and that's why the agent becomes vitally important to the process, because he's going to have a relationship with the underwriter. The one thing we allow our agents and encourage our agents to do is pick up the phone and call our underwriters and say, I'm at a $530 rate, my client needs a $510 rate, we need to get under $500, how are we going to get there? Well, let's put a $150 deductible on the RX, because you've got 3 people in there consuming $60,000 worth of drugs. If we put a $150 deductible on, that'll drop the rate by 3 points or 4 points. That takes another $30 or $40 out of the rate. That's the way we manage the cost of the employer. So, the other thing we're going to talk about is networks. Allied has access to many different networks. In Texas right now, we have our biggest network is Cigna. We use HealthNet, PHCS. We also have some narrow networks. When I say narrow network, does everybody know what I'm talking about? A narrow network would be, in Tyler, Texas, we have a unique relationship with the East Texas Medical Center. And we'll give you a quote that basically your people have to go to a doctor or the hospital at East Texas Medical Center. And you can say, why in the world would I do that? The reason is because they're 65%, the premium is 65% of what the normal premium would be. In other words, if I put 2 quotes next to each other, and I have the narrow network quote here, and I have the traditional Cigna quote over here, I'm going to be at $400 for the Cigna quote, and I'm going to be at $300 for the East Texas Medical Center quote. And the reason is because I already know my costs are less under the East Texas Medical Center than they are over here. Now, the other thing we're doing is we also, when I say reference-based pricing, does anybody know what that is? Okay. Reference-based pricing is a terminology you need to get used to and you need to understand. It's going to be reimbursements of medical services based on a percentage of Medicare. Okay? What's happening is, so when we go to Cigna, what do we pay per month to access in that policy? So I'm using a network, and I use Cigna as the network. My cost to access the network is $18 per employee per month. That's what it costs us just for the privilege of using that network. So what is that? That's 20 times, 20 bucks, that's almost 240 bucks a year, just for the, per person, just to access it. When we go to the Freedom Plan, reference-based pricing, there is no network. All we're gonna do is we're gonna reimburse the provider, the doctor, as a percentage of Medicare. And in our case, it's 125% of Medicare allowable for the physicians and 150% of Medicare allowable for the hospitals. Now, again, why is that even relevant? Well, if my price point for Cigna is 500 bucks and my price point for Medicare-based reimbursement is $400, somewhere along the line that's going to start to be attractive to an employer. Because I got to figure out a way to keep this plan in place. And my employees can go to any doctor that they want to go to as long as they'll accept the card that says Medicare-based percentage of Medicare reimbursement on it. So, reference-based pricing, pays provider, percentage of Medicare allowable, employee can go to any provider, there's no network access fee. We guarantee no balance bill back to the employee. Now that is a huge deal, which means if they get balance bill by the employee, by the physician or the doctor, we'll negotiate it and make it go away. Okay? It's 10 to 30% lower plan cost than a traditional PPO. One of the things that we have inside of companies like Allied, because we're small enough, we're extremely nimble, and we are constantly looking at cutting edge ways to keep costs down and to continue to try to offset this issue that we have of increasing healthcare costs. Let me give you a little background on Allied real quickly. We are not an insurance company, we're a third-party administrator. However, we look, feel, smell, and act like an insurance company. We underwrite, we pay claims, we do policy service, we have actuarial, we have a compliance department, we do product development, case management, sales, marketing, and a legal department. So we do everything an insurance company does, but we don't take risk. But we have some little companies here that are our risk partners. The one up in the upper left corner, how many are familiar know who Munich Re is? If you're an insurance company, person you do. Their actual paper is AAIC, American Alternative Insurance Company, but we also have relationships with Companion, Access, Fidelity Security, and Swiss Re. I think I have a slide here. Yeah, this puts this in perspective, okay? Cigna and Aetna have assets of 57 and 53 billion. Munich Re is 6 times bigger than both of them. Munich Re is 2 times bigger than IBM. So this is a major international company based in Germany. We have been underwriting their health insurance risk for the last 16 years. So they know us really well. So when it comes to Allied National, you look us up on AM Best, we don't exist. But you look up Munich Re on AM Best, you'll discover that there's not any companies that you're dealing with currently that are bigger than Munich Re. So you're actually 3 times bigger than IBM, almost. So, claims turnaround, we do our own claims processing, typically takes 10 days. Interesting thing happened, we have grown so fast, but right now if you called our office, you couldn't get through because we have 30,000 inbound calls coming a month. And 6 months ago or 8 months ago, over 10,000 inbound calls. We have grown so much, so fast, that we are now having to ramp up. We got to get a whole new phone system. We're outsourcing some of our calls to a local call center, and we're hiring people, 5 to 7 people every 2 weeks, trying to keep up with the growth that we've incurred because of everything that's going on in the marketplace. So our claims turnaround has not been as good as we want it to be. So you also have a self-service site. If you're an employer with us, an agent, you can access all the information about your case. So, and our website's pretty robust. I would encourage you to go look at it at some point when you have time. So, what happens next? Well, you need to contact Mike. We need a current census, current plan design, and current rates. And Mike's going to give you what we call a street rate, which is basically there's no medical load on it. It's just an indication of price, but it's not a final rate. Okay. You evaluate the street rate against your current renewal, and then if you want to, you decide it, and Mike will help you do this, decide that you're going to go through the process, you can you go ahead and start submitting all the forms for underwriting. It's a fairly labor-intensive process to go through underwriting, and it's for those of you that have not been through that, it's just asking for a quote. This is not a quote process. This is a concept sale. This is an idea that you got to put your head around, and you got to embrace it as an employer. Because it's going to put more responsibility on you as the employer. I did this presentation about 2 years ago in Dallas at Maggiano's, and I had a guy sitting down here to my left, and he got up at the end of me because he'd asked me a couple of really good questions, and He got up and he looked across the room and he said, I need to apologize to my agent. I said, why? And he said, because he's been after me for the last 7 months to sit down and have this conversation. And now that I've heard you talk and heard what you're talking about, he said, I just scared the snot out of me. My business really needs some help here because this is going to be a problem and I got to figure it out. And I've not had the time or the inclination to pay attention to this. Now I understand how big a deal it is, and now I got to pay attention to it. So he apologized to his agent, who had been bugging him for 7 months to sit down and didn't have time. So very, very important. I want to talk to you just to give you a little bit of an idea that there is some encouraging information out there, and to give you just, and this is, I'm going to close up with this, to give you a little bit of encouragement about some things that are creatively working in the marketplace today that are just now starting that could have a major impact on you and your group going forward. Direct primary care. This is really the country doctor in the technology age. How many remember Marcus Welby? Okay? So the country doctor in the technology age basically is a direct primary care physician has a relationship with you that has nothing to do with an insurance company. Really? Yes. So, primary care enables the individual to contract directly with the primary care physician for a fixed month amount. Involvement. The contract specifies services to be performed. The direct primary care may also include RX benefit, and some states allows the doctor to dispense meds, in some states they don't. But what happens here is that direct primary care focuses on wellness and relationship with the patients, not on insurance documentation. How many of you had an opportunity to be in front of your primary care physician in the last 60 to 90 days? How much time did he give you?
10 minutes.
Okay? Under this situation, you get an hour. Okay? Guess what? And you get him on a first name basis. And what else? You can call him on this. Can you call your direct primary care physician today on this? Is there a snowball's chance in hell of that happening? How valuable is your time? Okay? So, the thing that's interesting here is there's a movement afoot right now inside the physician community that basically said, we're tired of insurance companies. So, insurance agents and employers are not the only ones ready to throw the insurance industry out the window. And this is what's going on here. So, there's a new thought process here. So, what is a direct primary care physician going to do? Well, for that monthly fee that you're going to pay them, they're going to do annual exams, preventive screening, urgent care visits, lab work, sutures, routine illnesses, pediatric care, and they're going to do disease management. Now, this is really critical because we as Allied National see this as a huge opportunity to mitigate costs, and I'll show you why. Okay? We recognize the cost savings of direct primary care. The scope of the DPC services has to meet a basic standard of care. But what happens if we have a direct primary care arrangement? So he's your client, he's the client, he's got a policy, and he's got 11 or 12 employers, and you're the doctor, okay? We give you a credit that's sufficient enough for you to turn and write a check to him. So what he's going to do, he's going to get 50 or 60 bucks a month per employee, okay?
The hell he is.
Okay? per employee, okay? Okay, but then he's going to provide 24/7 direct primary care access to his employees. How many of those employees are going to come see him every day? None. Okay, if he has 600 patients and they're paying him 50 bucks a month, how much a month is he making?
You asked me to do math?
Yeah, 30 grand. Okay, that's $360,000 a year. How many direct primary care physicians today making $360,000 a year? How many patients is a direct primary care physician expected to see by the network they belong to? They're expected to see 2,500 to 3,000 patients in a year. Okay? The primary care physicians love this. They absolutely love it. So, what happens when the direct primary care meets our requirements? We're willing to do. We're gonna reduce rates by removing the office visits and selected RX benefits. We install larger deductibles and copays, and we free up the dollars to offset the cost of direct primary care. Okay? This is a win-win-win situation. And the reason it's a win is because the employee is going to have a better quality of care without the intervention of insurance company. There's still going to be catastrophic coverage, so if there's an event that requires a specialist or a hospitalization, the policy's still in place. Okay? The direct primary care physician is going to get paid more money than he would have got paid through the system that he's currently in, okay? And The carrier is actually going to have a higher degree of profit, which means we're going to reduce our costs. So if we have a direct prime, we have about 15 or 18 of these cases on the books right now. We have one, the flagship account that we wrote 3 years ago is a landscape company in Wichita, Kansas with 24 employees. Okay? The direct primary care physician essentially mitigated virtually every claim that they had because it was consumed inside of his services. We never had an urgent care visit. We never had a set of sutures. We never had an RX claim. Okay? So those claim funds on that policy were running $45,000 to $50,000 a year for 3 years. We get that company back $100,000 over 3 years. So they didn't use their claim fund. Okay? So all of a sudden now there's this economic business. Here's a company that if they'd been in the traditional health insurance world, they would have been spending somewhere north of $130,000 a year for their health plans. By the time we got through the refunds, including the direct primary care cost, their actual cost of insurance ran about $75,000 a year for 3 years because of the way that it was approached. This is what it looks like. So you've got the plan that you saw before, which is the claim fund, the aggregate stop loss, the specific. It's all still in play, and the employee still has deductibles and copays. But that direct primary care arrangement sits below it and becomes a buffer to the claims that would otherwise go into the claim fund or to the deductibles and the copays. Make sense?
How do you decide how much to do a direct primary care provider versus the claims fund? You know, so typically you're giving $300 in claims fund per employee. How much do you decide to split off?
Our actuarial model, that's what makes us unique. We know what the cost of that office visit is. So for example, I don't have time to show it to you today, but it's about an 18% reduction in cost. So depending on what the rate is, 20% of $400, $80. So if I'm going to reduce it to 20%, the other thing that will happen is if we have 100% participation and everybody that's an employee goes, we'll give you another 10%. And if you throw on top of that the Medicare-based reimbursement approach, there's another 7 or 10%, 20% credit. So what used to be $130,000 or $140,000 now became $105,000 or $100,000 or maybe even less. So the overall cost of the plan is dramatically impacted by all those different moving parts. So here's your answer. Okay, standard rate plan, $1,000 deductible, 80% co-insurance. The employee-only rate was $358. If I put a DPC wrap plan, $1,000 deductible, 80% co, there's no office visit, and I put a $250 deductible on RX, my rate's now $292, so I just saved $66. And our rating mechanism will do that. Part of the reason that this is working for us is because we recognize it. And down here, I went from a $1,000 deductible to a $5,000 deductible. My rate went from $358 to $222. Now I'm at 127 or 35% savings. This is real numbers. So I'm going to say one more thing, and then I'm going to be done, and we'll open it for questions. Are we good for time?
Yeah, well, pretty much.
Okay, good. So, do you have an agent? Do you have an advisor? If you have an insurance broker that all he's doing is quoting your insurance, you probably need to replace him, okay? Because if you look over here, under the old, prior to the ACA, basically we had benefit plan designs, market options, cost comparisons, and they got paid a commission. Okay, well now, your agent's going to need to help you understand ACA and Department of Labor compliance. How many have experience at Department of Labor audit? Are they fun?
They take your driver's license, your passport, all your bank account.
Everything, right?
Yeah, they want to know that you're not colluding with anybody internally.
It's amazing. Self-funding, medical underwriting, compliance, HIPAA compliance, ERISA, employment law claims analysis. Your agent now has to know all this and has to manage it on your behalf. And if they're not, you need to fire your agent. Okay? Typically an account, and got to remember, I'm an agency management guy, have been for 40 years. So the typical account was taking 40 man-hours a year. With all the new provisions that the agent's now responsible for, he's going to almost double his time on that case. So he's entitled to more money, which means you're going to see agents go away from commissions and start charging fees. He's going to become your strategic advisor, and it's not a one-year bid my insurance. It's a 5-year conversation about how do I mitigate these costs over the next 5 years. If you look at it as a bid situation, you're going to shoot yourself in the foot. So anyway, let's see where we are. Thank you. I appreciate your time. I've been kind of, I think I went over just a little bit. Okay. Great. Okay. Any questions, comments? Yes?
I've got three, actually. Three good questions.
Let's do this. We're going to do a panel.
Okay.
So I think we're going to just take a break.
We're gonna take a 5-minute break.